Good afternoon, students. Today, this is another session for drug dosing pattern according to the pharmacokinetic and disease pattern. So we have to decide the dose. So in last three lectures, we have discussed that, and we will continue the discussion. So our today's point is drug accumulation. So students, here in today's lecture, we will see this drug accumulation, and we also continue the topic which we have started from the last three lectures. So first of all, drug accumulation. What is drug accumulation? And during multiple dosing, whenever we are doing the multiple dosing in case of any infusion or in case of any infections, bacterial infection, or long-term treatment, in long-term treatment, when you are giving the multiple doses, at that time this problem will arise. And mostly in cases of certain drugs which are having ability to produce the drug accumulation. First of all, what is drug accumulation? When the drug stays in your life, in your body, stays in your body for longer period, though you have stopped its intake after the regular ingestion of the drug, though you have stopped the injection, though you are stopped taking of that drug, still the drug stays in your body, means it is accumulated in your body. And whenever you are giving the same drug after few period, still it will show its double or triple effects. So that is nothing but the cumulative effects. That effects most probably you will find in case of the drugs like digitoxin, because the half-life of the drug is 6 to 7 days of digitoxin. And though after 6 7 days, after long 15 days also, the drug don't completely clarified, don't away from your body, so it stay in your body. So its clearance is required for few more days. But again, if you give the drug, so it will start to show its more effects, more than the normal. So it is nothing but the cumulative effects. So here, during the multiple dosing, accumulation of the drug takes place. So when you are doing the multiple doses, means you are giving the 2 times a day or 3 times a day or 4 times a day, and for longer period, means for 10 days or for 1 month or for 2 months, when you are giving the multiple doses, so it may turn into, or it may get counted into the dosing accumulation. So it is very very critical condition, because nobody knows that which drug will going to be accumulated and it will show its cumulative effects, and it will become life threatening also in certain cases, because the drugs like digitoxin, they will drastically affect on your kidneys. There are also certain drugs which will affect on your liver. Certain drugs will affect on your brain. So what are the complications are occurring that you cannot easily evaluate from which drug or from which problem it has been arise. This occurs since drug from the previous dose, means in last therapy, due to the infection, whatever drugs you have taken, and though you have completed that therapy for several days, though after 1 month also, you may get that effects. Drug may be accumulated into your liver or into your kidney or into your brain, into your tissue cells. It may happen. So it occurs due to the from the previous dose is not completely removed, because the complete renal clearance won't occur. Whatever drugs you are taking, that must be completely washed out from your body through kidneys. So here sometimes it may stays into your body, the complete renal clearance not occurs, and it may it may result into the drug accumulation, dosing accumulation. So that's why the when you are giving the same dose, at next time you must give that drug very cautiously, and the concentration of also drug must be very small, by keeping that thing in your mind that it may produce the cumulative effects. That's why you must give its dose at very very minimum level, so that it will show its toxic effects. Accumulation is the function of dosing interval and elimination half-life. Because dosing interval, what dosing interval you have decided, that will be decided according to your half-life. And next is elimination of half-life. So after your half-life, how much drug has been eliminated, whether it is really eliminated or not, that you have to check out. And accumulation index is given as RAC is equal to 1 by divided by 1 minus e raised to minus kr. So your accumulation rate completely depends on your dosing interval, whatever dose you are giving, and what is the interval, means after 4 hours or after 6 hours or 24 hours or 12 hours you are giving dosing interval. And elimination half-life. Now for example, drug like lithium, it is having half-life of 24 hours. It stays in your body for 24 hours. So and when you are giving the next dose after 24 hours, means it stay in your body, still it is there, and it will start to show its cumulative effects. So here sometimes after 24 hours also or after 48 hours also, the drug won't completely clear from your body. So it may result into your drug accumulation. So drug accumulation is very very important things. When you are a smart physician or you are a smart pharmacist, you must consider this thing, drug accumulation, when you are giving the next dosing. Maintenance dosing and loading dose is based on the accumulation index. Accumulation index is also expressed as the ratio of loading dose and maintenance dose. Now here, now here you can see in this graph, at this point you are giving the dose. This is the concentration against the time, the multipliers of the elimination of the half life. So at this point you are giving the dose, so it increases like this, after it decreases its concentration, again here giving the here second dose, again increases, it's here coming to the low level, again here this is the third half life, fourth half life and fifth half life. Means up to this point it attains to the steady state concentrations, and from this point means it require minimum 4 half life, 1 2 3 4, and this fifth half life means you have reached to your steady state concentration. What is steady state concentration? The concentration at which you are getting its therapeutic effect, expected therapeutic effect, and the dose has been maintained in such a way that you won't get its toxic effect at higher level, and you won't get its uh, that you will get its effect, minimum effect concentration, means you will start to get its effects. Below this you won't get its effects at this dose, means suppose at this dose or at this dose you won't get its therapeutic effects. So it is the dose between the minimum therapeutic effects and maximum safety dose of your drug. So this is the steady state concentration. So you will continue with this dose so that you will get its effects. So minimum 4 half life required to attain the steady state concentration, and this is also comply to your renal clearance. Time to reach a steady state depends primarily on the half life of the drug, as we have discussed here. When Ka is greater than Ke, Ka means it is a constant for absorption, is greater than the constant of elimination. Its plateau is reached approximately 5 half life, means here plateau has been reached. So students, I hope you understood this graph. Try to understand. If you won't understand, tell me again. Again, I will repeat that, because this is very very important to understand how it will attain to the steady state concentration, how the half life plays a great role to maintain the steady state concentration, so that you will get its effects, start to get it effects. Fluctuation. Fluctuation is defined as the ratio of Cmax to Cmin. As you saw, the word fluctuation means increase, decrease very fastly. Fluctuation, as fluctuation you are observing in case of balance, weighing balance, fluctuation of readings. fluctuation. So you have fluctuations from Cmax to Cmin. As in case of mobile battery also, at one instant we are having the 100% battery, and on the next instant, on the next moment, it shows low battery. The same thing happens here also. Cmax to the Cmin means high concentration of the drug to the low concentration or minimum concentration of the drug. Greater the ratio, greater the fluctuation. Means if you are having greater ratio, so you will get the greater fluctuations. So that's why there should not be too much difference between your Cmax and the Cmin. It depends on the dosing frequency and half-life of the drug. Now here that can be summarized by the formula. Here you have to remember the formula. So CSS max, C steady state max is equal to CO divided by 1 minus e raised to minus KET. Again CSS minimum is equal to CO e raised to minus KAT divided by 1 minus e raised to minus KET is equal to C steady state maximum divided by multiply by e raised to minus KET. So this is the formula for CSS minimum and CSS maximum. Control release of the drug is attained by the decreasing of the fluctuation. Now here students, again we will discuss that point, loading dose and maintenance dose. So you need to be understand what is the maintenance dose and what is the loading dose. Now I will clarify all the queries, all the doubts in your mind regarding that loading dose and maintenance dose. So this video is very important for you. If it is possible, try to like it, share it and subscribe my channel. So here students, a drug dose not show therapeutic activity unless it reaches to the steady state. So in last slide we have discussed that what is steady state. So here, so from this point it have attained to the steady state concentration. So from this point the drug will show its effects. So any drug, if you want to show its effect, therapeutic effect, it must attain to the steady state concentration. So here, it takes a long time for a drug with long half-life to reach steady state. So in last slide we have discussed there are almost 4 half-lives are required to attain the steady state concentration. So for this reason, loading dose is allowed by the maintenance dose are given to achieve the steady state rapidly. Now students, try to understand and try to uh, get involved into this lecture what I'm telling you, and try to give your full attention what I'm telling. Now here we are discussing two terms, one is loading dose and another is maintenance dose. Now what are their role, what are their role to maintain the concentration into our blood, maintain the drug concentration into your blood and to show its effect. That is very important, to show its effects. So as we know in this slide that we have discussed, so at this point we are given the drug, but when we are getting its effects, we are getting effects from the fifth half life, means after the fourth half life, means this much time, this much lap of time has been wasted to attain the steady state concentration. Now we have to nullify this point, we have to nullify this time, because in emergency cases we must get the effect of drug very fastly. So for that students, here we have entered, we have introduced the new concept, it is called loading dose and maintenance dose. So for nullifying or for bypass this problem, we the new concept has been developed, it is called loading dose. So what is loading dose? It is the primary dose, it is a primary therapeutic dose which has been incorporated as the beginning. At this point it has been incorporated, and whenever you are giving that loading dose, loading dose is nothing but the, it is a double or triple quantity of your regular therapeutic dose. Suppose if your therapeutic dose is 100 mg, So your loading dose may be 200 mg or more than that. Means immediately your blood concentration will be increased. So here the amount of drug into the body means it is a blood concentration, and this is the half life. So here, as you are giving the loading dose, immediately the blood concentration of the drug will be rise here. Here you can see. So here it has been raised, and slowly it will decline. It will decline like this. So at the beginning, when you want the effect of drug from the beginning, so you have to give the loading dose. Once you are given the loading dose, and after that you have to continuously give the drug by infusion. Here you are giving by infusion, infused drug, and this is the loading dose. Loading dose always given by the in bolus, by the bolus way, by the bolus dose. Means you have to give the intravenous dose in by injection in one attempt. In one attempt, here you are giving the drug, and here by maintenance dose you are giving the drug by infusion way. We are infused drug means in normal saline you are giving the drug, means slowly drug will release into your blood, and it will start to increase its concentration into your blood. But here by giving the bolus route, means at one injection you are giving that drug into the patient's vein, and immediately there is a rise into the concentration will occur, and the increased concentration will give the effect of drug. From this point you will start to get the therapeutic effect, and it will slowly slow down. And at the same time you will giving the drug by infusion also, and it will slowly increase the concentration like this. So at this point, this is the half life of your loading dose. So at this point it will start to increase the effects, means it will not low down its concentration, means again it will start to rise, and again it will come to here. Again it will increase the dose, it will increase the concentration, means constantly it will increase the concentration of the drug into your body. Understood, I think. So in this fashion, by giving maintenance dose, it will try to maintain the concentration up to this area. This is the steady state concentration area. So at this point, when you are getting the effect, as well as you won't get any toxic effects. So this sort of concentration is going to be maintained into your body for a longer period, and that concentration is called as steady state concentration. So this dose is called as loading dose. It is the highest dose from which point you will get its effects. The concentration is very high, means there is Cmax in your body, and you start to show its effects. And this is the maintenance dose which you are giving in infusion in normal saline or in dextrose saline. The doctor will give that injection into saline, and slowly drug concentration will be increased, and at this point it will again rise, constantly rise, and already drug concentration is here, and it will start to show its effects from the point at which point you are giving the loading dose. So in this fashion it will try to maintain the steady state concentration. I hope you understood this concept. Expression for loading dose is given as XOL is equal to C steady state average multiplied by the volume of distribution. Expression for finding maintenance dose. Now it is a maintenance dose expression. X0 is equal to CXX average multiplied by the clearance of your drug. So in this fashion, this is the maintenance dose. Maintenance dose always accompanied with your renal clearance, because you are giving this dose in such a way that it will slowly clear it also at the normal rate, because this is the 3 half life, this is 6 half life, like this. So constantly drug will cleared also from your body, and will try to attain the at minimum and maximum concentration of your drug, so that it will show its therapeutic effect. So in this fashion the drug will try to maintain the steady state concentration. So in this fashion we are discussing this point here. If you have any queries, again you can ask me. I will again explain that. This is somewhat complicated, but once you understood, you will understood the whole concept for your whole life. It is very important for you to understand these concepts. Now, pharmacokinetic based designs of dosage regimen IV infusion. This is the simplest case as one deal with the infusion constant R0 only, no need to estimate the T. Now step 1, estimate the infusion rate, means at which speed the normal saline will release into your blood through intravenous route. So it is the estimation of the infusion rate. This can be done based on the required steady state concentration required. So R0 is equal to clearance into steady state concentrations. So in the first step, estimation of infusion rate will be evaluated, means at which rate the drug will slowly go into your blood, go into your body, and will increase its concentration. And step 2, estimation of the loading dose, means how much dose you have to give, that you have to decide. You cannot give the drug very blindly that this is the 1 kg 2 kg, give that. That is not the matter. You have to calculate that how much loading dose is required to produce its therapeutic effect. So this can be done multiply with the volume of distribution. Yes, what is the volume of distribution? That decides your drug, because multiple drugs are having their multiple volume of distribution. Some drugs are having 4 liters, some drugs are having 1 liter, some drugs are having 2 liters, some drugs are having 2.5 liters. So that decides. So that depends on your volume of distribution of the drug. Usually a loading dose is given and concentration is maintained by the infusion dose, as we are saw in this slide. This. So in this fashion, this can be done by multiplying the volume distribution, and usually loading dose is given and concentration is maintained by the infusion rate, means by the maintenance dose. Infusion rate means maintenance dose, means that at that infusion rate, that drug will slowly release into your blood. Extravascular means other than intravenous route, extravascular. So there must be some problems into your extravascular system when you are giving the drug. The estimation of dose and dosing rate after the extravascular dosing, for example, oral administration, is more complicated than that of the IV bolus dosing, because the rate and extent of extravascular availability would be important factors in the addition of other kinetic parameters. Obviously, because in intravenous, immediately drug reaches to your blood and it will start to show its effects, and also it will start to go to its half life, and after typical few period it will release from our body through kidneys. It happens when you are giving intravenously. But in case of oral route of administration, there are certain hurdles, there are certain obstacles. What is a major obstacle? Major obstacle is nothing but the first pass effects. First pass effects, because that drug will go into your liver for the first time, and again it will few percentage of that drug will be metabolized, and again it will come to the portal circulation, and from that point again it will go to the systemic circulations. So that will become the hurdle. In case of intravenous route, this point or this route is going to be bypass. In case of intravenous or intramuscular, in parenterals mostly, it can be bypassed. So that's why in case of oral route, it requires more time to attain the plasma peak level, and also it requires more time to attain the half life. Again it requires more time to have the biotransformation of the drug and to completely do the excretion of the drug through our kidneys. So that differs when you are giving intravenously and when you are giving the oral route of administration. So here it will become some critical it is not practical in case of the oral route of administration. So for that purpose you have to determine the different parameters. You have to go with the another calculations, because rate of elimination, rate of concentration, rate of excretion, so all the things is going to be varied when you are giving oral route of administration drug. Because of the complexity of the calculation involving absorption rate constants, in practice, the absorption of the most immediate release formulation is assumed to be intravenous. Yes, it is the ideal route of administration, because if you are giving the drug intravenously, definitely it will also increase the absorption, distribution, and also metabolism as well as excretion. All things will go smoothly when you are giving the intravenous. In such case, dose can be calculated by the same equation as that of the IV bolus. So in this fashion, we also discuss the point regarding the extravascular route of administration, and how it will affects when you are giving that drug by that route. Now, students, here are few formulas that you need to be concentrate here. So equations to compute individualized dosage regimen for various route of administrations. Here the route of administration, here are the dosage interval T, maintenance dose D or R0, and loading dose is DL, and equations. Now here we'll see one by one. For intravenous bolus, bolus means at one time you are giving the drug intravenously. So in that, T is equal to integration of Cmax infinity divided by Cmax raised to infinity divided by K constant. Again, D is equal to Cmax raised to infinity into V into 1 minus e raised to minus kt. Again, dl loading dose is equal to Cmax raised to infinity into V. Now, in continuous intravenous infusion, when you are giving into saline, normal saline or dextrose saline or in other saline, in that R0 is equal to CSS steady state concentration into clearance is equal to CSS K into V. Now DL is equal to CSS into V. Now intermittent intravenous infusion, T is equal to integration of Cmax infinity divided by Cmax infinity divided by K plus T. R0 is equal to CSS into K into V in bracket 1 minus e raised to kt divided by 1 minus e raised to minus kt, bracket complete, and dl is equal to r0 divided by 1 minus e raised to minus kt. Now in case of extravascular, t is equal to integration of c max raised to infinity divided by c max infinity divided by k plus T max. D is equal to C max raised to infinity into V divided by F. So in this, these are the formulas. Again, for average steady state concentration, so for any route of administration, this is the formula, at D is equal to CSS clearance into T divided by F is equal to CSS into K into V T divided by F, and final formula is DL is equal to CSS into V divided by F. So students, in this fashion, we have come across with the whole formulas. Try to recall the formulas, try to mug up it, and recall whenever it will ask, because this formula is nothing but the extraction of the points which you have covered yet. Okay, so this much is sufficient for today. If any queries will occur, you must contact me at any time. Okay, see you then for today. Goodbye.